Raquel Greer. Dr. Greer is a core faculty member here at the Welch Center and has really been instrumental in developing the collaborative care interventions. So she is going to be talking about chronic kidney disease, and I'm sure she'll do a great job. Thank you.
So, as Shinema said, I am an assistant professor in general internal medicine at the Welch Center. I am a primary care provider, and my clinic's actually up in Green Station. I'm a faculty for the Center for Telemetric Cardiovascular Health Disparities. And they asked me to include a couple of fun facts about myself, so I did. I enjoy traveling. So my husband and our goal is to eventually hit all 7 continents at some point. He really wants, I wasn't really gung-ho about Antarctica, but he wants to do it, so we will. And I grew up in a family that loved playing card games and word games, and we did a bunch of trash talking. So if anybody is up for a game of Scrabble anytime, I'm game. So the reason why I'm here talking today about chronic kidney disease is actually the focus of a lot of my research. I'm really focused on how can we improve the management of chronic kidney disease in the primary care clinics, because I think we need to really intervene early to improve patients' outcomes. And so at the end of this talk, you will be able to define chronic kidney disease and understand its health implications, recognize the risk factors for chronic kidney disease, understand and describe the treatment to help delay progression of CKD to kidney failure, as well as be able to engage patients in risk factor modification. So to begin our talk, I wanted to hear a little bit from you about what your experiences have been with chronic kidney disease. So whether or not you have a family, a history, have some experience with a family or friend who had chronic kidney disease, or with your patients and educating them about chronic kidney disease and modifying their risk factors for progression.
I used to work on a renal disease unit. We saw various types. We saw patients who was very compliant. We had patients that was non-compliant. And the hardest thing for them was the diet, or what they could and could not eat. But we had to educate. And the one thing we stressed is you really have to watch the foods high in sodium, high in potassium, because they want to go and salt. They want to still sprinkle that salt on the food, but you can't. There's other means. Salt substitute. You can use fresh herbs to give your food seasoning and flavor. It was very hard, and the fluid intake, that was one of the hardest things for them too as well. So what I did was, I did a little study. I took 3 different size cups, filled it up with ice, because they always wanted a cup of ice. They wanted the big cup of ice. Filled it up, and let them sit and let them melt, and see how much water was actually, the ice turned into water. Then that would determine for me if I'm going to give you this big cup of ice, especially if I know that you're on a fluid restriction.
No, I think that's important. I think, diet and food restrictions are a very challenging thing with patients with chronic kidney disease, especially when it's further advanced. So I think paying attention to how we can really educate patients about that. We're going to kind of be focusing a little bit on the earlier stages, and so usually when you get to the nephrology, when they get to the nephrologist's office and they're closer to kidney failure, that's a bigger concern, but we'll touch on some of those things today.
I think for me, working in the clinic is oftentimes when you're looking at sort of patients' lab values, and these are folks who may not technically have a diagnosis of kidney disease, but they may show some early signs where the GFR is less than 100, so maybe 60, 50, 40, and so sometimes I wonder and think what kinds of education should go into play when a patient, especially if somebody is African American, what kinds of education should we be providing patients, or how soon or how strict should our protocols be to sort of stick with a number that we see as far as the patient's glomerular filtration rate, and then when to refer them to the nephrologist for help.
Yeah, that's a good point. We're going to go through all of that. And I think educating patients early about their kidney disease risks and when they have kidney disease and what they can do to modify their risk is really important. And that's going to be the full focus of this presentation. We'll also talk about when to refer, because I think that is challenging. Again, a lot of my research has been looking at how well within primary care clinics do primary care providers educate their patients about chronic kidney disease, and it doesn't happen all too often, unfortunately.
No.
And so I think this is a unique opportunity where we can help them do better with making sure that patients understand that they have kidney disease and what they can do to modify their risk of progression. Because like a lot of things you learned about today, progression of kidney disease is preventable if you get the risk factors like diabetes and high blood pressure under control. So I'm going to be emphasizing some of those things throughout the talk. Any other experiences with family, friends, or patients, or challenges you experience with in terms of caring for your patients with chronic kidney disease?
Well, I have a family member, she passed chronic, she's end stage. I guess for me, everything I have encountered was end stage. Being in the hospital, you encounter end stage. You rarely encounter a patient with chronic kidney disease. If it is a chronic kidney disease, sometimes it could be a medication that's causing it or something like that. But for me, I always encounter them when they was end stage.
Okay, so it's kind of too late.
Yeah, and then let's talk about like how some folks are just on dialysis, like those patients that we're seeing and servicing in the communities and in our clinics, and we have a lot of family members who are just sort of on dialysis, and that's just their life-saving measure. And so some folks may not be as compliant about keeping their appointment to dialysis, and then they have a lot of admissions to the hospital for fluid volume overload, stuff like that. And then some patients just maybe have a hard time when it comes to the dialysis folks trying to access their shunts. So certainly helping people who have progressed to having to go on dialysis is another point that we have to be mindful of while in the community.
No, I agree. And that's, a topic of a whole nother area.
Yeah.
Because compliance among dialysis patients, especially among African Americans, is a serious concern.
Yeah.
And the separate question I'm looking at, a lot of those patients don't necessarily come to primary care anymore. So, it's, there's a lot of challenges with patients who are on hemodialysis. But I think you bring up some important points. And at least in my experience with some of my patients, a lot of them have family and friends who've been on dialysis. And one of the things that kind of led me to take this path, my career path, is the fact that I had a patient in residency who, his diabetes was really badly controlled. His hemoglobin A1C was like 10. And I was like, it's time. He was on all the oral medications. I'm like, it's time to go on insulin. And he completely refused. And it took me bringing him back over and over to try to understand why he was so hesitant to be on insulin. It wasn't because he was scared of needles or anything like that. And it was because in his mind, insulin meant that he was going to go on dialysis. Because when his grandmother went on insulin, she went on dialysis. And that was what he had believed in his mind was going to happen to him. And what I had to work to get him to understand was that actually, if you get your diabetes under control, your kidney disease won't progress. Or at least it will be delayed, and you won't have that outcome if you really take control of your diabetes right now. So I think patients have a lot of misconceptions about kidney disease that we really have to explore as we start to work with them to help them take care of the risk factors for kidney progression. Another common misconception is patients are like, well, I'm not having any back pain, so my kidneys must be fine, because they just associate it with that. Or that they're still peeing fine, they're still urinating fine, so their kidneys are working. And that all of those issues with urination or fluid buildup or shortness of breath or fatigue, all of those things happen at the very end when your kidneys are really about to fail. Really up until that point, you're really asymptomatic from your kidney disease. But that progression is preventable. And so a lot of what I'm going to talk to you today is about how we can engage our patients in self-management of their CKD risks. So again, most of the patients that you're going to, that have chronic kidney disease are actually managed in primary care. We say kidney disease and you're like, oh, okay, well, why aren't they seen by a nephrologist? And unfortunately, there aren't enough nephrologists to see all the patients who have kidney disease. And so again, the primary care provider that primary care provides an important opportunity to do several things in order to manage patients' CKD risks. Once, your goal is to identify patients who are at risk for CKD. You also want to be able to recognize it and diagnose it early and assess its severity. And then you also want to then figure out what the patient's risk factors for progression are and make sure you're treating those. You also want to make sure you're engaging patients in risk factor modification. What can they do to treat their hypertension or diabetes better to delay their progression to kidney failure. And then also you want to be able to make sure that they're referred to a nephrologist in a timely fashion so that they can do everything they need to do to prepare for renal replacement treatment if that's where they're headed. So I'm going to walk through all these steps with you today, but to make sure we're all on the same page. So beginning with, what do the kidneys do? Well, the kidneys are two kidney bean-shaped organs that are kind of right here in your back, and they filter waste and extra fluid from the body. And the way I get patients to understand that is like, if you drink a boatload of water, you're actually going to urinate a boatload of water because your kidneys are responsible for keeping your fluid in balance. So as your kidneys fail, if they're failing, then your kidneys aren't doing that work, and so that fluid starts to build up. And so chronic kidney disease is actually abnormalities in the kidney structure or function that's been present for 3 months. And this figure here kind of shows the clinical course of CKD. So again, we all start off with normal kidneys, and then there's some people who are at increased risk for chronic kidney disease, such as have diabetes or high blood pressure. And now, if those are uncontrolled, that can lead to kidney damage. And then that damage, if it continues to worsen, can lead to a decrease in kidney function, which then can progress to kidney failure, where the patient might require dialysis or a kidney transplant to replace that function. And so patients who have CKD are at increased risk for several bad outcomes. One, they're at increased risk for heart disease, for hospitalizations, for death, and of course progression to kidney failure. And at every step, even those who are at risk for those bad outcomes, and then that risk increases as you get closer to kidney failure. So again, it's important for us to intervene as early as possible to reduce patients' risk of having these bad outcomes. So who's at risk for chronic kidney disease? Again, I said that you don't have symptoms from chronic kidney disease until it's really advanced. So you need to know who to screen early for the presence of kidney damage or kidney dysfunction. And so the risk factors for kidney disease include diabetes and hypertension. I'm going to say that again, diabetes and hypertension, diabetes and hypertension. Those are the two leading causes of kidney failure. Other clinical factors include cardiovascular disease, history of acute kidney injury, and a family history of CKD and ESRD. So if people tell you those things, they should be getting screened with a BMP and a urine test to check for their kidney function and for kidney damage. Other socio-demographic factors include age, so if they're older than the age of 60, they should be screened. And also, that's me, sorry. Can you drop it? Yeah, sorry. And then race and ethnicity. So actually, African Americans are 4 times more likely to develop kidney failure than other races. And that's the same for Hispanics are also at higher risk, Asian or Pacific Islanders, and American Indians. So those populations should be targeted for screening as well. And so how do you screen these patients? You do 2 tests, which include the estimated glomerular filtration rate, which is derived from the serum creatinine, and that's your measure of kidney function. And then you also do a spot urine test for albumin or protein. And so I'll go through what albuminuria and proteinuria are. So again, you use those 2 tests to come up with a diagnosis of CKD. And so again, CKD is a presence of either kidney damage, which is the presence of proteinuria and a couple of other things like history of kidney transplantation, or decreased kidney function, which is a glomerular filtration rate less than 60 that's been present for at least 3 months. So what is urine albumin? So what the kidneys do actually is they act as a filter, and so they keep they filter the toxins and the extra fluid out, and they keep all the important nutrients and proteins in the blood. And as there's kidney damage, some of those important proteins like albumin leak into your urine. And so if you detect albumin in your urine, that's an indicator that there is kidney damage. And so dependent on how much protein you measure in the urine, it's suggestive of how much damage there is. And so if there's less than 30, that's considered pretty much normal. If there's 30 to 300, if the albumin to creatinine ratio is 30 to 300, that's considered moderately increased. And greater than 300 is considered severely increased. So when you send that test to the lab, you'll get an albumin to creatinine ratio back, and then you can categorize patients appropriately. And so when you send off a BMP or NCMP and it has a creatinine, you automatically get an estimated glomerular filtration rate, again, which is a measure of kidney function. It tells you how much function that your kidney has. So for example, if you have a GFR of 90, then the percent of kidney function is 90%. If your GFR is less than 15, then the amount of function you have left in your kidney is less than 15%. That's an easy way to think about it. And so this is kind of a nice schematic to show it. Just cross that out. This is like an old staging system. But the new staging system that they just came up with kind of uses both the GFR, which is on this axis, and your albumin to creatinine ratio on this axis to categorize patients into different risk groups. People who have a normal GFR and really no albuminuria are considered normal, so they're in that green section. But as you get a little bit of slight dysfunction or increased proteinuria, you go to yellow, and then even more, you go to orange. But those who have the lowest GFR and the most proteinuria are considered red, and those people are at the most risk for developing bad outcomes from their kidney disease. And those are the people who are most likely to develop heart disease, most likely to develop hospitalizations, and more likely to progress to kidney failure.
I have a question. So with this chart, is this how you can determine if somebody's having an acute kidney injury versus kidney disease?
So it tells you the severity of their kidney disease.
Okay.
And based on where they are in the chart, it can also help guide your treatment. How
Okay.
aggressive are you going to be in terms of how often you see that patient, who needs to be referred? Because again, if you're in this category, in this red category, you're at highest risk for developing those bad outcomes. And so you're likely going to want to see, and I have a chart later on, but you're going to want to see those patients at least 4 times a year at a minimum to gauge where their kidney function is, and also make sure that the risk factors are under optimal control. So this tool, I think, is important because, again, we know that CKD is preventable, so we just want to make sure that we're targeting the people who are at increased risk to make sure that we're seeing them very often and make sure we're doing everything we can to prevent their kidney function from progressing, their kidney disease from progressing. So again, the key thing to know about chronic kidney disease is that it's preventable, and so the treatment is geared towards delaying or preventing kidney failure and the complications that are associated with CKD. So as CKD progresses, people can develop anemia and bone and mineral disease. We tend not to do so much of that treatment in primary care offices. At that point, they're usually referred to a nephrologist, so I don't spend too much time talking about it in these slides here. But in terms of what we are responsible for taking care of is ensuring that we're treating all the patient's risk factors for progression. And those risk factors for progression are blood pressure, diabetes, and proteinuria. Those are the key things that put the patient at the most risk for progressing. So in terms of blood pressure, you want to make sure you get your blood pressure under control, and there's different goals of therapy based on the amount of protein the patient has in their urine. So if they have no albuminuria, so their albumin to creatinine ratio is less than 30, the goal is the standard blood pressure target of less than 140/90. But if you have any amount of protein in your urine, so greater than 30, then they're at even more increased risk for progressing to kidney failure, so you want to be a little bit more aggressive in terms of your blood pressure target. So you're going to want that to be less than 130/80. Given in mind that if you have an older patient who's at risk for falling, you probably aren't going to be as aggressive, and so again, you want to individualize your target the same way you do with the other goals, but just keeping in mind that if you can be, you want to be as aggressive as possible in terms of their blood pressure goal here if they do have proteinuria. For diabetes control, you want, again, their hemoglobin A1C to be less than 7, which is probably consistent with the other talks that you've seen. You want to make sure their diabetes is under good control, because again, if they're what additional do I have to do? And this is the additional thing that's kind of unique that you need to take into account, and that is avoidance of nephrotoxins like NSAIDs and IV contrast dye. And this is a graph that kind of illustrates why that's important. So most people think that your decrease in your renal function is kind of this like nice linear line. You decrease by so much amount every year. Well, what likely happens is that there's likely insults along the way that kind of accelerate how fast you progress to kidney failure. So say, for example, you have like a 50-year-old with hypertension and diabetes, and their hypertension and diabetes is relatively well controlled. You don't think there is anything more to really do, anything more that you need to be aggressive about. But they come in with gout, and so they're prescribed a high dose of naproxen. But naproxen can actually injure the kidneys and can cause kidney function loss. And so what happens, he takes the NSAID and his kidney function drops. It may rebound a little bit, but it may not come back to normal, and then it kind of goes along at a slightly different rate. And then he comes into the office and says he has chest pain, and he ends up in the ED with needing a coronary catheterization that requires IV contrast dye. IV contrast dye can also lead to kidney injury, and now his kidney function drops really quickly again, and then he kind of plateaus out, and he comes in with a new infection, and he gets put on a medication that can injure the kidneys, and then it drops again, and the next thing you know, he's in kidney failure. And so what should have been a nice slow decline ended up being much more rapid because of these preventable events that led to quicker progression. And so I think what's important to keep in mind is that patients with CKD are at increased risk for adverse safety events, so medical errors. And so it's important that we remind patients to, one, they need to be aware of their chronic kidney disease, but they need to notify all providers that they have CKD. We all know that electronic medical records aren't, it's not great. So if if they get care at an emergency room, down the street, they may not have access to his primary care provider's clinic notes and may not be aware that he has CKD. And so unless the patient tells them that, they may not know, and they may prescribe NSAIDs or one of these other medications that might lead to harm. So it's important for patients to know that they have CKD and let their other providers know. It's also important to notify their providers of all the medications that they're taking, even the over-the-counter ones, because again, NSAIDs like Aleve, Motrin, ibuprofen, Advil, they're all over the counter. And if they don't know that they have kidney disease, they may be taking this and you may not even know. And so it's important to make sure that they tell their providers everything that they're taking, including the supplements. And so you also, again, want to emphasize to avoid NSAIDs, and I like to actually name them and write them down so they know all what the different NSAIDs are. So it's like Advil, Aleve, naproxen, Motrin, ibuprofen. And then they also need to know that because some medications are cleared by the kidneys, that their medication doses may need to be adjusted as their kidney function declines. And so it's just something for them to be aware of. Another thing that's really important is that one of our roles is to make sure that patients understand what kidney disease is and what they can do to prevent it from progressing, and that they have some control over it. The same way that Dr. I'm going to say Shiati, I can't say that. Dumoulin said about is that making sure that patients are knowledgeable about their health and that they actually have some control through their self-management. They can prevent progression. But this is a nice study that kind of illustrates that most patients don't know that they have chronic kidney disease. So it was the NHANES study, so it was nearly 3,000 participants across the US, and they all had CKD, and they were asked, do you have a kidney problem? And you can see that, and this is CKD stage, so this is mild CKD, so they have actually normal kidney function, but just some damage. This person has a GFR, this group has a GFR less than 60, so 60% function left, and this is stage 4, which is a GFR of 30, so 30% function left, but they're one stage away from kidney failure. And what you'll see is that actually this is only 3.7% of stage 1 people know, 7.8% of stage 3 participants knew, but of the people who were one stage away from kidney failure, I keep doing that, only 42% knew that they had kidney disease, which is alarming. And there, again, like NSAIDs, all those things can lead to kidney injury if they're not aware of it, but there's a huge population of patients with CKD who aren't aware. And so I think this is why I think I'm happy I'm here giving this talk, because I think one of your roles could be really to make sure that patients understand their CKD diagnosis and what they can do to prevent progression. So again, we want to increase patients' knowledge and awareness of CKD and their CKD risks. And we want to engage them in patients in self-management of their CKD risk, which is the same as what you'll see elsewhere, which is adherence to their medications, lifestyle modifications like diet and increase their physical activity. But the thing that's unique here is reminding them to avoid NSAIDs. Yeah.
Are there any particular supplements besides over-the-counters that like stand out to you as being big?
The key ones are the NSAIDs. Now, there's so many different herbal supplements out there. I can't think of one off the top of my head that would be, that's particularly known to be injurious to the kidneys, but I think it's important just to have patients be in the practice of telling you everything that they're taking, just in case. Any other questions?
I know some prescribed medications can cause kidney injury, like for instance, antiviral regimens can be harsh on the kidneys.
Yeah, so there's certain medications that you tend to be a little bit more cautious with if the patient has kidney function, and then you just have to check their kidney function regularly while they're on it, if it's something that they have to be on. But certain antibiotics like Bactrim can cause kidney injury, and then there's certain antibiotics that you want to avoid if they have some kidney function decline.
Thank you.
But has anybody had any experience with, like, how do you feel about educating your patients about kidney disease? Do you feel like when you talk to patients about it that they understand, or do you find it difficult?
I think for me, even though I can look at the numbers sometimes, like if the patient doesn't have the diagnosis of kidney disease, but they may have some numbers that look a little funky, like it could be, then I really won't mention anything about it. But if the patient has a diagnosis of for it, they've already spoken to the provider about it. If someone had questions, I would certainly go over. But I've seen a lot of labs where patients had sort of GFRs less than 90, and I didn't see a referral to the nephrologist or even a diagnosis of anything about their kidneys. But 9 times out of 10, those patients are also hypertensive patients too. So having this information is great for them, so that I can use this as my arsenal and be able to help patients better.
No, it's good.
Yeah.
So I mean, there's two things to keep in mind. I mean, so there's kidney damage, and so if they have protein in their urine at any greater than 30 at any point, they're considered having CKD. GFR in and of itself, unless it's less than 6, if there's no evidence of kidney damage, less than 60 is a marker for having chronic kidney disease.
Okay.
And that's the important thing to keep in mind. But sometimes primary care providers shy away from educating their patients about kidney disease because people know nothing about it. You know, people have limited knowledge about what the kidneys do, and so providers in general admit that it's a little bit harder to explain kidney disease to patients. And this is a helpful tool that the National Kidney Disease Education Program came up with to help facilitate that education in the clinic. And so it kind of walks through what the GFR is, and it uses this tool, kind of like a gas tank, to show where, based on what their GFR is, if they're considered normal, moderately decreased, or severely decreased. And it has on the back of it some easy ways to explain kidney disease to patients. So it walks through what is kidney disease, how do you check it, how do you check for CKD, what happens if you have CKD, and steps that they can take to prevent or delay kidney failure. It's a nice way to walk through and explain what kidney disease is to patients, and they can they put in their numbers, they put in their blood pressure goal and diabetes goal, and they actually walk out with a handout that has a lot of information about what they need to know, that they need to do to prevent progression.
Do we have that?
So I think it should be in your patient education binders.
We have that.
Yeah. And I also,
I'm actually not sure.
Is this linked? This link on
It's a link to it, yes. It's on the NKDEP one, and it'll take you on their website. You can have access to this tool.
And if you don't have it, you can definitely make copies of it and hand them out.
And this is that heat map again, that again categorizes patients based on their GFR and how much the quantity of their albuminuria. And pretty much it tells you the number on the bottom indicates how often that patient should be seen and have their GFR, their kidney function assessed, and their blood pressure and all their other risk factors. And it also tells you at what point you should refer. So say you have a patient who has a GFR of 28 and an albumin to creatinine ratio of 298, then you can see that, okay, so a GFR of 28 is in this row, and his albuminuria is moderately increased. So it says I should refer that patient to a nephrologist, and that patient should be seen at least 3 times, have their GFR assessed at least 3 times during the year. So at least, I guess, should be seen every 4 months approximately. If they're in this bucket where they have GFR less than 15, then they should be seeing a provider at least 4 times, if not more, during the year. So it's an easy guide to say, okay, well, how often should I be seeing them? Should I refer this patient? Should I not? But here are all the indications for when a patient should be going to a nephrologist. So the ones that are bolded are just absolutes. If a patient has a GFR less than 30, they should be going to see a nephrologist. And the reason for that is because they've gotten to a point where their kidney disease may progress and they need to be seen by a nephrologist in a timely fashion so that we can start the discussions about renal replacement therapy. Also, that's around the time that they're likely going to develop complications related to their CKD, like anemia and bone and mineral diseases. So the nephrologist would be the one who would assess and treatment and manage those conditions. Albuminuria greater than 300, so it's severely increased, would be another indicator that patient should be seen by a nephrologist for further assessment. Some of the other indications for referral would be acute kidney injury or abrupt sustained fall in GFR or rise in creatinine. Those would usually warrant it, and sometimes, not always, but sometimes it's really clear why it happened. The patient was dehydrated, had an illness, diarrhea or whatever, and they had an abrupt fall in their GFR, but it came back up after their illness resolved. That doesn't necessarily need to be seen, but if they have an abrupt fall and it's unclear why, and it doesn't resolve, then those patients should be seen. If they have rapid CKD progression, so their GFR declines by more than 5 that year, that's much faster than what would be expected, and those patients should be seen by a nephrologist. If they have hematuria or blood in their urine, they should be seen. If they have refractory hypertension, meaning that they're complying with their regimen, they're on 4 or more agents, and you still don't have it under control, those patients should be seen by a nephrologist. If you have difficulty with their potassium levels, recurrent kidney stones, if you don't know the cause of their CKD, those patients should be referred, and also those patients who have hereditary kidney disease, like polycystic kidney disease. Most of those people already are seen by a nephrologist. They've been seen by a nephrologist for a while, but if not, then those would be people who should be referred. Any questions about that? So again, the key points are patients with CKD are at increased risk for progressing to kidney failure. And so really the treatment goal is to delay or prevent progression. And so the way to do that is to target the risk factors for progression, such as blood pressure and diabetes control. I don't have proteinuria treatment, write that in, that should be on there. Lower cholesterol, lifestyle modifications like physical activity and low salt diet. And again, the unique one that you haven't seen before and haven't had a lecture about yet is avoidance of NSAIDs. That's the one that's unique for chronic kidney disease, and one that's probably going to be the least mentioned by their primary care provider, and the one that we need to make sure that patients understand to prevent their risk of progression. And so these are some websites that are really helpful. They have some really nice patient tools on them. So the National Kidney Disease Education Program has that tool to help guide a discussion with the patient about their chronic kidney disease and what GFR and their albumin numbers mean. But they also have some nice videos that kind of show you how to explain CKD and the different treatment options to patients to kind of illustrate that. And the National Kidney Foundation is another one that has some really nice patient tools. And so these are the links for them, and I think some of them may also be available to you in your binder that you'll get. Any other questions at all? I think I went through all of that really quickly. Anything else? Okay, go ahead.
What about patients with like a recurrent urinary tract infections where maybe that the provider is thinking that the urinary tract infection could have caused some problems with their kidneys? Have you seen any issues like that?
So I know that, so I guess so recurrent urinary tract infections, are you asking whether or not what the cause of it was, and whether or not that's related to the kidney disease, or whether or not?
Like if the bacteria like could progress to the point where it's affecting their kidneys, is that possible?
No, it is possible. And that's called pyelonephritis, which is essentially an infection of the kidneys. And so, you start off with, a cystitis, which is an infection of your bladder, and then it just kind of, if it's not treated quickly enough and unrecognized, then it can progress up the ureters and then also start to affect the kidneys themselves. And that tends to be a more serious infection where the patient may have pain and fever, nausea, vomiting. They're just more systemically ill from that infection, and it requires more aggressive treatment. Some patients need to be hospitalized for it, but not all the time. But that's where urinary tract infections can actually lead to kidney problems. Anything else? All right, well, I gave you guys a little extra break.